Okay. Welcome everyone to this webinar on state strategies to expand access to PACE. I'm Neva Kay, a senior policy fellow at NASHP, and I'm going to be moderating today's webinar. Today's webinar draws on the work of the 5 states that participated in the NASHP State PACE Action Network. We are highlighting the work of 2 of the states that illustrate the efforts of all 5. And our hope is that this information will help you advance your own efforts to increase access to PACE. Next slide. So our agenda for today is as follows. First, I'm going to tell you a little more about the network and the work of its members. Then you're going to hear Maryland's approach to selecting and onboarding new PACE organizations from Laura Goodman. And Laura will be followed by Daniel Cohen, who's going to speak about Massachusetts' work to improve the PACE enrollment process. We have reserved some time for questions. Please feel free to send them in during the webinar via either the Q&A or the chat feature. And we do ask that at the close of the webinar, that you please follow the link to the very brief survey to share your feedback. Next slide. NASHP, in partnership with the National PACE Association, convened the NASHP State PACE Action Network in May of 2021. The network consisted of teams from 5 competitively selected states. And the goal of the network was to help states with existing PACE programs expand access to those programs. These states received 8 months of group and individual technical assistance. And we are very grateful to the funders who supported the work. They are the John A. Hartford Foundation, the Gary and Mary West Foundation, the Henry and Jeanette Foundation. Next slide. Oh, it's coming along, okay. The 5 states that formed the network were Iowa, Louisiana, Maryland, Massachusetts, and New Jersey. All 5 made very good progress in their efforts to expand access to PACE. Next slide. This slide gives you the highlights of these states' efforts and accomplishments during the time of the network. And just to summarize, 4 of the states, all except New Jersey, joined the network to further their efforts to secure new contractors. During the span of the network, these states all established a selection process, and 3 of them, Iowa, Louisiana, and Maryland, have already identified their new POs, PACE organizations. It's notable that 2 of the states developed selection efforts that assisted them with other aligned policy goals. Louisiana, for example, is working to move Medicaid beneficiaries with severe mental illness who live in nursing homes into the community and viewed their PACE organizations as potentially strong partners in that effort. And therefore, they included a special focus on behavioral health in their RFI to ensure that the new PACE organizations they selected would be ready to serve this population. And as you'll hear shortly, Maryland sought to expand access to PACE to rural areas. Among the 5 states, both Massachusetts and New Jersey opted to use the resource offered by the network to improve their PACE enrollment processes. Both made progress, and today you're going to hear about Massachusetts' approach and improvements. Next slide. And with that, I'd like to turn to Laura Goodman, who is going to present Maryland's approach to selecting and onboarding new PACE organizations. Laura is the Deputy Director of Maryland Medicaid's Office of Innovation, Research, and Development. Laura?
Thanks so much, Neva, and I'm glad you gave my title because it's very long and now I won't have to do it. So good afternoon, everyone. Getting some feedback. I'm delighted to be here this afternoon to share a bit of Maryland's experience as we've endeavored to expand our PACE footprint here in our state over the next few years. So I want to first thank NASHP for the invitation to be here today, as well as for accepting Maryland into last year's collaborative. So that opportunity provided us with the ability to more easily garner knowledge from other states, which has both helped to shape our process to date, as well as to inform some of the upcoming work streams that I'll touch on over the next few minutes. Next slide. So I'll focus my time over the next few minutes on the process that Maryland developed to select new PACE providers, starting with what prompted us to expand, then our solicitation process, and our next steps. Additionally, at the very end, I'll provide a couple of comments on how Maryland is approaching PACE expansion in rural counties. Next slide. Next slide. So how did we get here? The bottom line is that PACE is a key part of Maryland's strategy for offering integrated care, particularly for dual eligibles in the state. So the Maryland Department of Health, or the department as I might refer to it, has a pretty long history of looking to develop comprehensive statewide audacious duals programs and in not quite getting them across the finish line. So for example, in the mid-aughts, our trend was toward a managed long-term services and supports program. More recently, in 2016, we developed a concept note for a duals accountable care organization. But in the absence of a major programmatic overhaul, the department shifted its focus to a menu of programs to support duals, PACE being principal among them. So we know PACE will remain small and not blanket a state's older adult population. But there are many appeals to the program. So in addition to being a fully integrated, capitated program, PACE has the added benefit of being off the shelf. So we have seen firsthand how challenging and time consuming it can be to develop a new authority and shuffle it through the approval process at the federal level, whereas PACE has existing authorities under both Medicare and Medicaid. In addition, we also had a popular PACE program in the state, Hopkins Elder Plus, and there's a couple of highlights on that program here on the slide. That program was part of the original PACE demonstration in the 1990s, and they have a territory covering several zip codes in East Baltimore and the vicinity. Next slide. So this slide shows the progression of our expansion process here in Maryland. As I noted, Hopkins Elder Plus opened in the late 1990s, and for 20 years or so, Maryland had regulations that limited the state from opening additional PACE sites. So with the identification of PACE as a key dual strategy, in 2018, we changed our regs to allow additional PACE sites. In 2019 and early 2020, we started planning in earnest and then got sidetracked by a certain global pandemic. We did manage in 2020 to submit a budget initiative for the consideration of the governor and the legislature in 2021. So once we received that budgetary approval, we convened a working group consisting of subject matter experts on PACE and LTSS from both the Maryland Medicaid program, as well as our data and policy partners from the Hilltop Institute, which is part of the University of Maryland, Baltimore County. And I did see some of our team for both Medicaid and Hilltop on the call today. One of the prime motivations for this work group was to identify and roll out some kind of selection process. So after changing our regs to allow for additional PACE providers, as I mentioned, the department started receiving expressions of interest from many different interested potential PACE organizations to set up shop here in Maryland. So we realized quickly that we'd need to develop a process to manage our expansion. We released a solicitation last fall, which I'll give more detail over the next few slides. Then we announced our selected providers 2 months ago in March of this year. And you'll see from the timeline that we're currently in the throes of multiple work streams. And we're hopeful to start enrolling participants into the new sites starting next year. And I did see some representatives from some of our new sites attending the call today as well. Next slide. So this is, I'm going to spend a little time here because this is part of what really took up a lot of our bandwidth last year, and especially where the NASHP collaborative did help us to hone in on a process. So how did we design our selection process? First and foremost, we talked to several different states to whom we could not be more grateful. I see some of you here today. We spoke with Pennsylvania, DC, Virginia, and Colorado. Among other topics, we asked them about their PACE provider selection vehicles, if any. These ranged from RFIs to RFAs to RFPs. And after starting the NASHP collaborative, NASHP also pointed out the model used by New Jersey, which is a competitive letter of intent. After applicants are selected during the LOI or letter of intent round, and they're invited to proceed toward the CMS application. So that approach ended up being a good fit for us, and we are exceptionally grateful and indebted to the team from New Jersey for speaking with us last year as we were working on this process. So we did glean from other states some other design decisions. First, we made the decision to only allow one PACE organization per service area, which we defined as counties. But given that some zip codes straddle multiple counties, the actual service areas are defined by zip code. Applicants were permitted to apply for more than one service area, but they had to submit separate LOIs for each one. And we also asked other states about what is the pace of PACE in terms of growing it. And we settled on initial caps of 200 participants per site. And another major design decision is that we are going to require our PACE organizations to submit PACE encounter data to us. Next slide. So going back to the pace of PACE growth, again, we are starting with caps of 200 participants for the new sites. And having overseen only one PACE program for the past 20 plus years, we needed to make sure our expanded program was manageable for our state staff. 200 is also the current cap of the existing Hopkins Elder Plus program. For the initial expansion, we focused on areas of higher population density. This was a decision to trend that way to ensure both available provider networks as well as a participant pool to sustain the program. So that led us to decide on 3 service area, West Baltimore, the zip code's not currently covered by the Hopkins Elder Plus program, and 2 counties in the DC metro area. Additionally, we were interested, as Neva said, to see if any providers wanted to give it a try for opening up in a less populated county. So we opened up our process to rural providers and gave ourselves the option to select up to 1 with a smaller cap of 100 participants. Next slide. So with those design decisions in place, it was time to put out the call for provider applicants. Next slide. So the process we designed looks like this. Anyone here from New Jersey or who has worked with New Jersey PACE will recognize these steps. We remain incredibly indebted to the New Jersey team for pioneering this process and for being so generous with sharing their solicitation documents. In state government, we don't call it plagiarism, we call it not reinventing the wheel. So in general, the first step that we had in our model is a comprehensive letter of intent. This was the only competitive phase of the process. So with our providers selected for each jurisdiction, each successful applicant was invited, and again, this happened in March, to proceed to a round called the Request for Additional Information, or RAI. The RAI is intended to position the PACE organizations for the CMS application. Concurrently, the PACE organizations will need to work with Maryland's Office of Healthcare Quality, which is our regulatory agency for adult medical daycare licensing in the state. Of course, after that, the state readiness review, PACE agreement, and which is not listed on the site, service provision and enrollment. Next slide. So on this slide, I will ask you to travel to the Baltimore area where we all remotely convened every 2 weeks over the past year to get this done. We utilized New Jersey's template to Marylandize the solicitation document last summer. That may or may not have required some nights and weekends in addition to our biweekly meetings. We posted the resulting solicitation right after Labor Day weekend and gave applicants 2 months to reply. We did build in the opportunity for potential applicants to ask us questions, which we accepted both during email and during a virtual pre-solicitation conference that was held a few weeks after we posted the solicitation. So we released several iterations of frequently asked questions on or before September 30th. And that gave applicants a month before the early November deadline to take those clarifications and build them into their letters of intent. So you'll see from this that we took nearly as long to evaluate the letters of intent as we gave the PACE providers to develop them. We received a lot of interest in our expansion, which was amazing. Of course, we could only select 1 per jurisdiction or county, and we announced those selections in mid-March. That said, we will see how this goes. We are hopeful that this will not be our only round of expansions, so there will be future opportunities for other providers. Next slide. This slide just provides a quick overview of the contents of the letter of intent. In addition to a comprehensive cover letter, there were 4 sections. The first asked for the applicant's history of providing PACE and/or home and community-based services. The second asked them to demonstrate familiarity with their service area of interest. Section 3 is where applicants describe their approaches to service delivery, and the last section focused on financial capacities and risk. So the 4 sections were weighted equally by the evaluation panel. Next slide. And here's where we are today. So the RAI phase is largely, as I mentioned earlier, a step that bridges the letter of intent with the CMS application. So we're giving our selected applicants up to 6 months to turn in their RAIs. We held a full group kickoff meeting in early April and are now holding bi-monthly individual check-ins. Since the letter of intent is the only competitive phase, we're now working collaboratively with each new provider. Next slide. So where are we headed now? Next slide. We have a detailed internal work plan, and I'm indebted to our colleagues at the Hilltop Institute for organizing that. I've grouped it here into 4 broad buckets. So first, the PACE organizations are working on their RAIs, which are due in October. Some of them are aiming to move a bit quicker and make it the September CMS application window. Simultaneously, we're working on onboarding documents and processes, and the NASHP Collaborative provided a lot of great information and resources to glean from. And this also includes defining referral and eligibility workflows. As I mentioned earlier, we do plan to require PACE organizations to submit encounter data. Our partners at Hilltop are developing a data collection instrument, and we'll be launching a work group with the PACE organizations to develop the process together. Lastly, as may be evident, we need some more staff. We're pivoting from managing one existing PACE organization that has just churned on for 20 years to developing processes for 4 new sites, plus the additional onboarding activities, state readiness reviews, counter data reporting, and so on. Next slide. So before I talk for a minute about our rural approach, a couple of quick lessons learned. So after sinking a lot of effort into developing the solicitation documents, the need for frequent and thorough communications kind of snuck up on us. We ended up using an existing joint Medicaid LTSS email account as our single point of contact to field questions and other requests. One thing I might do a little differently next time is to be prepared in advance with templates for receiving, logging, responding to, and disseminating frequently asked questions, as well as for formal communications. Additionally, and this is a fun one, we were floored by the number of letters of intent that we received. The challenge stemming from that is that we required more time to evaluate the submissions than we had planned. We remained largely in an informal communications blackout during that time, but several applicants and interested stakeholders did reach out on a semi-regular basis to inquire about the status. Lastly, while we were working on the solicitation, frequently asked questions, and evaluation, most of our other work streams, such as the ones I mentioned, onboarding, encounter data, staffing decisions, those all came to a grinding halt. Probably similar to other state agencies, our whole team has been working on this expansion in addition to our regularly scheduled job descriptions. So now that we are in the RAI phase, all of those other work streams are bearing down on us pretty hard. Next slide. So the NASHP team asked if we could spend a couple of minutes to discuss our rural site. So as I noted earlier, we included an optional rural site with a smaller cap of 100, in addition to the 3 more populated expansion counties. So as a result, we ended up selecting an applicant for Allegheny County, which is in Western Maryland. It's about 2.5 hours from the Baltimore area. Now, this is not particularly rural compared to some of the larger states, but for Maryland, it's all relative. The selected PACE organization operates existing sites across the line in Pennsylvania, and they're also aligned with a major health system in their proposed counties. So we think that those 2 pieces are going to help them to sustain, the PACE program with a smaller population cap, and to maintain the provider network that they have available there. And we're just eager to see how it goes. So We also, I know during the collaborative, there was a lot of really innovative ideas that came up for supporting rural sites. One was a mobile interdisciplinary care team. So we're eager to see if other states end up rolling these types of innovations out. And this is my last slide. Basically, I'm just indulging myself because I love a good map slide. This shows the population density of PACE. Thank you, Luke. Sorry about that. Eligible by zip code. The existing and upcoming PACE sites are circled in red. You can see Allegheny County towards the left-hand side out west, Montgomery County, Prince George's County, Baltimore City, and Central Maryland. You can see we're really covering the population centers with this current expansion round, so we'll need to be really thoughtful about how we expand going forward. And I've left my contact information here as well as our website for our PACE program. So just again, thank you so much to the NASHP team for the invitation and for organizing and running the collaborative. And I'll turn it back over to Neva.
Thank you, Laura. That was really helpful information. As I had said earlier, we will hold a question and answer period at the end of the webinar, but do type them in now because then we'll have them stacked up and ready to go when we get to there. And now I'd like to introduce Daniel Cohen, who is going to present Massachusetts' work on improving the PACE enrollment process. Daniel is the Deputy Director of Integrated Care in Massachusetts Medicaid program. Daniel, you have the floor.
All right, thank you very much. We can move along to the next slide then. So I wanted to start by saying that the NASHP opportunity arrived at the absolute perfect time for Massachusetts. We had reorganized the organization towards the middle end of 2019, and that included reorganizing how we approach the PACE program. At that point, I joined the PACE team. We were able to increase our staff capacity and had a number of goals to expand and modernize the program. NASHP really gave us something to organize around and to bring together the local stakeholders at Mass PACE, as well as the PACE organizations and the state government. The four goals that we articulated were first to revise our consumer outreach and enrollment policies. We had concerns that PACE wasn't always being presented on an equal playing field with the other managed care choices that our members have. So we did things like revise call scripts and such, and we have completed that first phase of the project, although in terms of member materials, there's always more room to grow and improve. We really wanted to ensure that sufficient PACE capacity exists around the state by closing what we call the PACE deserts. We needed to revise the policies that we had created around zip code expansions. And we were able to move forward this year with 4 of our PACE organizations requesting service area zip code expansions to CMS. We are expecting approval hopefully any day now. And that new map significantly adds opportunity for people who didn't previously have access to PACE to join one or more PACE programs. And so the zip code expansion phase of our project is also complete. We also intend to revise our enrollment policies, and that's what I'll be talking about more today, to reduce the number of days between a person raising their hand and saying, yes, PACE is right for me, I would like to join, and the date that they actually enroll in the program. And so that is in flight, as is our intention to align PACE's contractual requirements with some of the best practices across our other programs. Our restructuring created an integrated care unit that brought our PACE program as well as our DSNP and our Medicare and Medicaid plan demonstration under one administrative roof. And there are a lot of ways of doing business at each of those programs that are excellent. And we would like to streamline those across the 3 programs when it makes sense in order to create efficiency both for the state government and for the organizations that oversee multiple products in each of these different spaces. Next slide, please. So today we're zeroing in on our second goal, to decrease the number of days it takes for folks to enroll in the PACE program. There are a lot of changes that we need to make on our end in order to streamline that process. Some of the immediate challenges being that there's no clear documentation of the process. We've been relying on historical memory instead of a standard operating procedure. We've had PACE and MASS since I think 1991. So it is much more senior than some of our newer programs. And as a result of that, a lot of policies and procedures were developed under a way of doing business that isn't how we do things today. We also noted that our PACE organizations and our mass health enrollment teams sometimes had differing understandings of what the exact rules were. And even when a breakdown occurred in the process, sort of where exactly the breakdown was taking place and whose responsibility it was to address it. So we tried to zoom out and take a really global look at how the entire process works, and then look for opportunities to assign ownership when things aren't working the way they're supposed to, and to cut out or streamline steps when possible. In the summer of last year, we conducted a full analysis of the current process, and we did that by interviewing key informants at the PACE organizations, as well as our own Mass Health clinical team, which plays a role here, and then the Mass Health Enrollment Center. Next slide, please. So this slide is supposed to scare all of us because it's terrifying. This is the process today to enroll in PACE in Massachusetts. Someone goes through all of these steps at the PACE center. That application eventually gets passed off to the Mass Health clinical team, as well as to our enrollment team. You can see that a lot of these arrows go back and forth. And some of these processes can take a significant number of months. So ideally, it should only take less than a month to enroll in the PACE program, but there are times that it is stretched 2, 3, or 4 months, and that is what we are trying to address. The next slide, series of slides actually, I think starts to summarize what some of the key concerns were from each of these different stakeholders as articulated in the process flow map. So if we can go to the next slide and focus first on some of the concerns raised by the PACE organizations. One of the problems we have in Massachusetts is that if you are currently enrolled in Mass Health, you're not exempt from the asset verification process. So in a lot of ways, we handle asset verification through our application process. And so we essentially are putting Mass Health members through a new Mass Health application in order to join the PACE program. There are multiple requests from our enrollment center asking for materials that PACE organizations say that they've already sent over. So there is an issue around tracking and being able to point to some of those errors as information flows back and forth. At the time, there was no process for a current PACE participant to change PACE organizations. We do have overlapping PACE service areas in Massachusetts, especially in Boston, where we have more than 2 in some places. And there are sometimes instances where someone needs to switch from one to the other, and we've already established that they're eligible for PACE. So that should be seamless and not treat someone like they are a brand new PACE applicant. As I said earlier, our orgs sometimes say that they would get inconsistent answers to their questions from the MEC, depending on who they were speaking with. And then in some extreme circumstances, enrollment can take up to 5 months. The next slide, please. On our clinical team, today, our nurses manually review every single submission of clinical eligibility, even though we have an algorithm at Mass Health that can determine whether or not that submission passes the threshold to establish clinical eligibility for the PACE program. So you can see how creating a manual process when we could automate it instead creates the opportunity for delay. PACE programs are required to resubmit if updates are needed. So if the manual review indicates that there are issues, they resubmit the application. It's not something that they can simply update. And then at the time, questions from PACE organizations to us would arrive through a whole variety of avenues. So emailing our virtual gateway, calling a nurse directly who you happen to know, calling me, sending emails, reaching out to the MEC directly. So we needed to streamline the communication so that our team could appropriately respond. And then lastly, on this next slide, our member enrollment center talked about receiving applications that were incomplete and were missing information. I think that speaks back to the need for a really clear understanding of exactly what's required. Again, to my earlier point, fielding multiple inquiries on the same case coming in different directions or directed towards different staff. And then just acknowledging that this is a really specialized program with specialized enrollment policies that require some focus and expertise. And we have to acknowledge the bandwidth of the fact that these enrollment folks are also handling enrollment for the entire 2.5 million mass health caseload. So next slide, please. So what are we going to do about it? As a result of participating in the NASHP PACE Action Network, we have made the following improvements so far. We required each of our PACE programs to set up a dedicated and secure email address to receive and respond to questions from our clinical team and from our enrollment center. That way, it wasn't centralized with an individual at the PACE program who may go on vacation or may go and find another employment opportunity. It lives in a very specific place that is accessible to whomever at PACE needs to have access to it, and it works the same way on our end. We moved to electronic transmittal of the clinical eligibility confirmation. We used to mail and fax this pre-pandemic. So we have now moved to a process where once eligibility is established, our nurses complete and email off the clinical eligibility record to that secure inbox. We also clarified a few pieces through a new bulletin in January where we eliminated the annual MDS, which is how we establish clinical eligibility for participants who happen to be in a long-term care facility. The facility is already doing that work, and so the member is having to sit through 2 identical assessments, and the information is coming to us twice. So we were able to eliminate that activity for the PACE programs. We also, recognizing our own responsibility for when applications take longer than they should, we extended the allowable time between an initial assessment and enrollment in the program. So if for whatever reason you applied to PACE and it took 91 days to get you enrolled, at the 91st day, we would normally have said, you know, that clinical assessment's no longer valid. It was too long ago. We need you to do it again. And so eliminating that step eliminates duplicative work, but it also owns responsibility for where some of the delays in the process are a result of processes that we want to improve. And then we did find that there was a need to clarify who exactly needed to sign those documents before they're submitted to us. We only need registered nurses to sign, but there were times where some organizations thought they needed a physician. And so that means they held applications for a longer period of time while they organized that extra signature that wasn't necessary. Next slide, please. We also established a process for a smooth transfer between PACE organizations when it's necessary. In addition to the work we did at Mass Health, our PACE programs have been working internally to identify steps in their own process where there are delays that they believe they can address themselves. And so in partnership, we hope that we can bring that entire time period down, both on the PACE side and at the state side. Next slide, please. So I wanted to highlight some of the continuing steps, because even though this project is wrapping officially in terms of our partnership with NASHP, it really did set us on a stage. We are organized in how we do this work. And so we're going to continue to push forward some of the next level initiatives. So we had moved from faxing clinical letters of eligibility to emailing them. We are now moving to automate the delivery of those notifications. So when the system it has been told that a person is clinically eligible, it will automatically send out a letter to that PACE inbox, as well as to our enrollment center for the members' records. We are about to implement that sometime this summer. We're thinking July 1st may actually be the implementation date. And we did, if it's helpful to know, use some ARPA dollars that we invested in the PACE program to help us fund some of this data work. Additionally, and in companion, we are going to automatically adjudicate the clinical assessments to establish clinical eligibility without manual intervention. Our nurses will still manually review any MDS that comes in and does not pass. clinical eligibility, and then they'll work with the PACE program to see what information may have been missing. If both the program and our nurses agree that this person truly is eligible, we just need to update the application. So for these two things, we are ahead of schedule on both of them. I thought they would come out at the end of this calendar year, but it looks like July 1st is when we will be able to roll out this suite of new improvements. Do I have a next slide? Yes. So then there's even more stuff. So these are some of the things I'm looking forward to having completed in the early stage, but there's sort of a next steps. So we have established a cross-agency work group to dig into some of the larger policy changes that we believe are necessary in order to eliminate some of those things, like having to essentially reapply to Mass Health when you're already on. We have to be careful about how we do that. It involves changing regulation. It could involve moving where PACE regulation lives within overall Mass Health regulation. So it's complicated, and we don't want to mess anything up by accident. So we brought a team together of the right people, and we have identified outside project management resources to help us shepherd that initiative through the organization and keep us moving forward. As I said, we may move PACE out of the long-term care regulation where it lives now to something that looks more appropriate, maybe alongside some of our managed care regulation. We believe that we already have a lot of the information on file inside Mass Health to process a lot of the things that are required in the application. So we want to see if there are ways to streamline the application by only asking the PACE program to collect what we're missing, rather than asking them to go ahead and treat the application package from scratch and gather all the materials. And then as we move forward with all these kinds of changes, it's important to factor in time for system build, including testing, because, you know, these are the kinds of things that you want to a certain degree, be slow and steady and make sure that everything is going to go right before you launch it and mess around with people's eligibility or their enrollment. And so we're building in that extra time. And so the second half of this year is heavily focused on these types of activities in terms of shrinking the time it takes to enroll in the program. Next slide, please. And that's the last one. My contact information is here as well. I am always happy to talk about the PACE program. So if you have any questions at all, if you want to brainstorm, if you want to tell me something really exciting that you're working on, we'd love to hear from you. So please reach out to me at the email address below. And thank you.
And thank you, Daniel. I mean, both of you just gave some great information. A reminder, please use the Q&A function or the chat to send in your questions. In the meantime, I want to let you know that we have recorded this webinar and we will be posting on the NASHP site. So if you wish to share it with your colleagues, you will be able to do so. And we will make sure that those who participate know when it has been posted. We did get a question for Daniel, which was, does Massachusetts have PACE throughout the entire state?
Not yet is my answer. So we have a multi-phased approach to addressing the PACE deserts. Phase one is to work with our existing PACE programs and offer them the opportunity to expand their zip codes. So if there is a town that really makes a lot of sense for them and they think they can cover, we gave them the opportunity to do that. And so that process is complete in that we've submitted those to CMS, and when they come back with the new map, that will add a really big chunk of the state to the PACE covered service area. Our second phase of expansion is focused on, again, allowing our existing PACE programs to open new centers in parts of the states that we identified as either not being served at all by PACE or being underserved. And so we're hoping to see expansion out to Southern Massachusetts, Cape Cod, and to Western Mass in particular as a result of those expansions. And then when that process is over, our phase three is to look at what's left over and try to figure out how do we tackle it. I think it's likely that we will get to mainland statewide, but Martha's Vineyard and Nantucket are always challenging for us to cover for all of our managed care programs, just due to the size of the population on the islands. You can't get to them except by ferry, and then the amount of providers that are on the islands.
And another question for you, Daniel, is Massachusetts, is the MDS used for eligibility only for nursing facility participants, or is it for everyone? And do you use an eligibility screen or pull all of the information from the MDS?
So the MDS is used in PACE to establish clinical eligibility. We use it in our other managed care programs to establish rates. So that is, we're not necessarily going to use that in the PACE program, but we are going to change the way PACE interacts with the MDS. And we want them to think of it not just as a tool for establishing eligibility, but a tool for us to really understand the acuity and the health needs of the population. And so our PACE programs have been working over the summer and fall, or they started in October of last year, on kind of really beefing up how they approach that MDS document. There's a separate application for things like income, residence, location, et cetera, that the MDS doesn't capture, that we use to establish eligibility.
Okay, thank you. And we have a question for Laura. What barriers were there to expanding PACE in 2018? Were policymakers concerned about startup costs, long-term budget impacts, social scalability, et cetera?
Absolutely. Thanks for the question. So the regulation to only have one, to limit us to one PACE provider, had been in place since long before I started with the Maryland Department of Health. So I can't speak to the history of that. But we did not encounter too much resistance when we lifted that. In terms of the budget initiative, of course, we did get a lot of questions on why Maryland pursued that, because of, PACE being a capitated program, kind of has a savings component in the rate setting process. However, we did think that there are some folks, given the eligibility criteria, the income threshold for PACE is a little bit higher. So there are folks who would be new to Medicaid coming onto PACE and represent new costs overall. So we figured out what that would be and created some population and growth estimates on which we based our budget request to the governor and the legislature. And luckily, because the Maryland Department of Health had identified PACE as being a key strategy for our duals, we didn't really encounter too much resistance to that, even submitting it in the middle of the pandemic, putting in a budget request. It wasn't very large, and it was definitely one of the few that was approved. So we didn't really encounter any resistance from policymakers. Kind of an everyone likes PACE approach.
I actually have a question for both of you that I think would be helpful to listeners. I'll start with you, Laura. So when you were, in your presentation, you explained how you adopt the New Jersey approach, which has a competitive letter of intent and then the follow-up with selected contractors. Can you just elaborate a little on what you saw as the benefits of that approach for you?
I think what we were looking for here in Maryland was the ability to conduct a selective process that was not a formal RFP. And I think the competitive LOI was a good fit for us. And of course, we did a lot of background, procurement law scouring to make sure that it was acceptable for us, which it was. But being able to see a potential PACE organization's vision and where they would like to be, and was really important to us, without having folks go all the way down the line and, kind of get to the CMS application phase. We wanted to make it a manageable amount. Of course, we do recognize how much work the applicants did put in, even though it's called a letter of intent. They were quite lengthy and comprehensive, but we wanted a way to, I think the most important thing was to have a window where we heard from all interested providers all at once, and not necessarily have a rolling process by which, if someone wrote to us and expressed interest in a particular county, we allow them, and then 3 months later, someone else comes and, wants the same county, but we've already made the decision that we don't want to share zip codes or, county spaces. I think the biggest influencer there was the ability to kind of have a finite application window that all potentially interested folks would have to reply.
Thank you. And Daniel, it's a very similar question. You made the decision to go with a zip code expansion first. And why did you decide to take that approach?
Yeah, I think that's an easy one. We really tried to say to ourselves, people in certain parts of Massachusetts don't have access to PACE, and that's not fair. That's wrong. So how do we address that most efficiently? And so the fastest way to expand a program is with an existing, already approved by CMS, already in the Mass Health Network program. So we looked to our current PACE programs and said, if you were interested in expanding, this is the time window to do that, and we will support your applications. We did ask them to tell us what they were doing so that we could troubleshoot any places where, oh man, no, we can't have 6 PACE programs in this town with 10 people. That doesn't make any sense. And luckily we didn't have any of those instances. So we were able to move forward, and everybody who wanted to move forward was happy, and nobody had to give up any potential zip codes. We're doing this in a phased approach because zip codes alone, they just don't get you all the way there. And opening a new center, as Laura knows, comes with a whole suite of activities. It's a different kind of CMS application. It's a different kind of oversight at the state. You got to go out and buy, equipment. And if every Band-Aid is not in the building's not opening on time. And so our first phase gets PACE to more people fastest, while we work on preparing, much in the way that Maryland did, to release an application for new centers. And frankly, that application will be the Massachusetts-ized version of the Marylandized version of the New Jersey document, because Laura's already shared with me all of the background materials to help us as we get these documents over the finish line and out into the public.
Well, it's nice to see that payment continues forward. Laura, we do have a question for you. It's, by having a competitive letter of intent and limiting zip codes, would this be a hindrance to nonprofit programs versus for-profit programs?
Yeah, so we welcomed applications from both for the LOI for both for-profit and non-for-profit organizations. So we did, I guess I can't really speak to that as someone who's never worked for a PACE organization, but we did not expect it to be a hindrance to either or.
And did you get applications from both?
We did.
Okay. So, Laura, one of the things I'm curious about is that you said you got lots of applications, and I'm still really curious about, in particular, the rural areas. Did you get multiple applications for that?
Without disclosing too much information, because they're
Yes, I know you're
right.
saying
We did get more than one. So and that's why we're really excited. Hopefully we're able to learn a lot from this first expansion round, and then hold some more because we did get some interest.
Right. And I'm very excited too, because it's going to be great to learn from your experience.
Yeah.
And we have a question for Daniel. What might be some of the anticipated effects of more closely aligning PACE with the other Mass Health managed care initiatives?
Sure. I think we hope to see, we like to make it easier for members to understand the differences in all these programs. And we'd like it to be easier for us internally and for folks administering them to do so as well. So sometimes it's simple things like we get 3 different reports that we call 3 different things that are really the same thing. Sometimes there has been certain work, particularly in our demonstration, around putting the member at the center and really focusing on the member's role in care team development. And I think there are opportunities to think about bringing some more of that language into the PACE program. And conversely, PACE really knows how to run a care team and has a lot of expertise there that we can bring into some of our other programs. In our SCO program this year, our DSNP, we're putting a lot of emphasis on member advisory boards and how they're organized and structured. And over time, I think that's a discussion I'd want to have with our individual PACE programs. How are you all running your consumer advisory boards, and what kind of participation are you getting in them? And what can we learn from the work that we just did in our other programs as we start to open the hood on this one?
Mhm. Actually, Daniel, that made me think of something. I'm curious. PACE really coordinates so much the care for its members, but I'm wondering, the family caregivers still stay strongly involved. So when you're thinking about those advisory groups and such, are you including family caregivers on
Yes.
them?
Yes. So for example, our One Care Implementation Council is made up of 51% members, people who would be eligible, or their families. So for instance, if you are the parent of a child with disability, it is important for you to have a voice on those committees. And the same principle applies to all of our stakeholder engagement groups and discussions, and is something that we would like to continue to hold on to.
Okay, thank you. So one of the other things that drew my attention that I hadn't realized you had done before, Daniel, was to set up more policies about helping smooth the transition from one PACE organization to
Yep.
another. And I wonder if you can talk a little bit more about those.
Yeah, it's frighteningly easy. So structurally inside Mass Health, it's essentially as simple as flipping a button. And so what we need to do is create a process whereby we don't want to create an environment where PACEs are poaching from one another constantly. So we want to understand what's the circumstance that's causing a person to want to transfer. It's also an opportunity to do a spot check and make sure they're not leaving because they weren't getting care, or they weren't getting something that they should have been getting at the PACE program. So our first activity in these rare circumstances is for our PACE manager to really understand the specific case and the specific circumstances. And if we agree that there really is no problem, this is just a member preference that makes a lot of sense, we are able now to flip a switch behind the scenes and literally move that person's file from one PACE program to another PACE program.
Great. And then I'm going to ask you the question that I always ask about your work on enrollment. Can you possibly give us a sense about the resources that it took to go through that process? Because I personally think that this is something that could be really useful in a number of different situations.
I agree. We were really fortunate when we organized to bring more support to the PACE program, which was really a one-woman show for a long time. And so we have a deeper bench of folks on our PACE team, including Kayla King, our not new anymore, but newish PACE and SCO program manager, who took the lead on this initiative by setting up key informant discussions with all the different PACE organizations, by getting to know the folks over at our enrollment center and on our nursing team, and having an open discussion with them about, what are the problems from your perspective? And it was her job to really take what she heard across those three audiences and not argue it with them, but really receive it and then put it into build something that was digestible to us. And in the background, she's been working on things like turning this into a standard operating procedure, establishing what the rules are with a date stamped document that is officially approved and that all parties have. And so we have a resource to go to that does require dedicated staff time, but this particular project, that time is not overwhelming. What is overwhelming is the what do you do about it piece. So the data systems pieces, the policy and regulatory changes, lawyers need to participate in that, et cetera. So that's one thing that sometimes it's easier to articulate the problem and what you want to do about it. And then the bigger challenge in state government is actually how do you address it?
Okay. And I just want to pause and see if we have any more questions from the audience. Again, you can use either the Q&A function or the chat function. No. If not, I actually do have one more question from Laura about the rural expansion, which is you settled on a cap of 100. And was there, what was the thinking behind that?
Sure. This is a couple of years ago that we did this, so I'm trying to dig back in my memory. I think it was maybe the rural option was a later add-on to our request for letters of intent. And I think it's what kind of fit in our minds in terms of our budget initiative, which had already been approved for a certain number of people. So, and, I guess if we thought starting, with caps of 200 for highly populated areas, that we would start with smaller for more rural jurisdictions. So I don't know that it was super formulaic, but we didn't want to push our budget limits too high or too far, because we'd already kind of put in our budget request based on the high population areas. So again, kind of maintaining, is partially a factor of how many PACE eligibles would there be in a particular set of zip codes. And partially we needed to manage it for ourselves because we've never done this before.
It is. And, to make a financial go of it in the urban area, it's good to have that 200. And I wonder if you had any questions about the finances of the 100, whether that would trade, but no. Okay.
Well, I think that's what we're testing. With smaller populations, could a PACE organization literally sustain a program in a rural area?
Okay.
Yeah.
Thank you. And so again, I just want to remind everyone that after this webinar, well, not immediately, but within the next day or two, we will be posting the recording and the PowerPoints on the NASHP website, and we will let people know that that has been done. And with that, I would like to conclude today's webinar. And I want to thank you again to our speakers and all of you for joining the webinar. I would also like to thank our partners at the National PACE Association, and one more time, our funders, the John A. Hartford Foundation, the Gary and Mary West Foundation, and the Harry and Jeanette Weinberg Foundation. And finally, I want to thank NASHP's own Luke Pluta-Ellers for all of his hard work in support of the network and today's webinar. And finally, please don't forget to complete the evaluation. Good afternoon.